Hello and good afternoon. This is Nicholas Courtney with the National Congress of American Indians. Thank you so much for joining us for our first webinar on the Affordable Care Act 101, an overview of the ACA and benefits of the AI-AN marketplace enrollment. I have the distinct pleasure to introduce Donnig McDonough of Health System Analytics. He is also a technical advisor to the Tribal Self-Governance Advisory Committee and consultant to NCAI. Before we get started, I'd like to introduce you all of how you can be participatory in this webinar. You will see on the screen in front of you that our GoToWebinar service and model is in front. You can open and close your panel using this orange arrow. You can select and view your audio by using your telephone. However, we have disabled our audio for you all due to the number of participants. We ask that if you have any questions or comments during this time, that you submit them in the questions text box. You are also available to email me at ncourtney@ncai.org. A recording of this webinar will be made available on the NCAA Policy Center website and YouTube, as well as tribalhealthcare.org. Without further ado, I'd like to present Donnig McDonough, who will present to you our presentation outline.
Thank you, Nicholas. Appreciate the opportunity to go over the Affordable Care Act and benefits for American Indians and Alaska Natives, particularly in relation to marketplace enrollment. But as you see on the slide here, we'll be looking at marketplace enrollment as well as Medicaid enrollment and the impact of the Affordable Care Act over the last soon-be decade of the Affordable Care Act being in place. The slide here, just for reference, are a number of acronyms that are included in the presentation. They're defined later, but just as a reference, you have them here. Might want to set that aside for reference. Another document to reference is we'll be looking at household income and eligibility levels. And so the slide showing here shows for the marketplace, for eligibility determinations made in this calendar year in 2019, these are the figures for eligibility levels there. Just to note that in most of the year, the federal poverty level that's used for eligibility determinations for the marketplace are slightly different from those used for Medicaid. Right when Medicaid releases, right when the federal government releases the updated FPL levels, Medicaid adopts those immediately, versus the marketplace, that whatever FPL levels are in place on the first day of the calendar year, on January 1, that FPL levels stay in effect the full year. So again, these are the marketplace numbers. The Medicaid numbers would be just slightly different, but they would be a little bit different. They would be the 2019 FPL levels. All right. Section 1, overview of the Affordable Care Act provisions. One is Section 10221. And as you may know, the Affordable Care Act was enacted, but it's really two pieces of legislation, the Affordable Care Act and then the Indian Health Care Improvement Reauthorization and Extension Act. A separate piece of legislation was attached to the Affordable Care Act and then passed by the Senate, passed by the House. So it's a piece that modifies solely the Indian Health Care Improvement Act. There are other provisions dealing with American Indians and Alaska Natives that are in the Affordable Care Act itself, and a couple of those items relate to the payer of last resort, provisions when IHS or tribe are liable for payment, as well as express lane option, which deals with simplifying enrollment into Medicaid. There are also general provisions that have components of them that are specific to American Indians and Alaska Natives, such as the cost-sharing reductions or cost-sharing protections that are made available to enrolled tribal members, and that's in Section 1402. So we have the overall Indian Healthcare Improvement Extension Act and permanent reauthorization, so it's in law and it doesn't need to be reauthorized, it continues. Second are Indian-specific provisions in the Affordable Care Act, and then the third are general provisions that have a particular component that's specific to American Indians and Alaska Natives. Starting with the Medicaid changes, in the Affordable Care Act, it authorized states to implement Medicaid expansion covering all the legal state residents up to 138% of the federal poverty level, somewhere around $16,000 for a single household. And the federal government would pay at least 90% of the funds. That was pretty much a mandatory component on states in the Affordable Care Act. There was a Supreme Court challenge by some states that said it was a burden on the states, even though the feds were picking up at least 90% and in early years even more. But ultimately, it went to the Supreme Court and the Medicaid expansion became optional. So today we see roughly 14 states that have federally recognized tribes that have not expanded Medicaid coverage today, whereas 21 states with federally recognized tribes have expanded Medicaid. So that conversion over to making Medicaid expansion optional has had kind of a negative impact in Indian country. Individuals are working across states, particularly in South Dakota and in Oklahoma, where there's the largest concentration of individuals who would be eligible, IHS eligible individuals who would become Medicaid eligible if their states were to extend Medicaid up to 138% of the federal poverty level. In addition, there were, under the Affordable Care Act, revisions to the base Medicaid program. The most important, really, I think, is the simplification of eligibility determination. They eliminated asset tests except for the elderly and disabled population. So now someone comes in and documents their income. That's sufficient. You don't need to be figuring out whether they've got any assets in the bank or things like that, which oftentimes make things much more complex on eligibility determinations. Also, health benefit package requirements. It did give greater flexibility to states on the benefit package, but also brought in new requirements on what needs to be covered, such as preventive services. And then finally, showing on the slide there, presumptive eligibility, excuse the typo, presumptive eligibility for adults in addition to children can be allowed by a state whereby a initial determination that someone appears to be eligible allows them to be enrolled, and then later on the additional documentation may be needed, but it allows the determination to be made more readily. Moving on to changes in the Medicare program, a significant change for the Medicare enrolled population, or for those in particular that are on Part D prescription drug coverage, where an individual would pay a premium, the federal government subsidized the remainder of the premium, and individuals would have cover under Part D if they choose to. The way that the program has been working as it was initially set up is the Part D coverage would start right when someone initially had needs. Then it would have a gap, which was called the donut hole, whereby the individual themselves had to pick up all the costs. And then when the costs got to a certain level in total, the coverage, the Part D coverage, would kick in again, with the vast majority of costs picked up by the federal government or the health plan, the private health plan that's under contract through the federal government, and the individual will pay just a little bit. So what the Affordable Care Act has done is phasing out that donut hole, the no coverage gap, and it's just about eliminated now. So that was an important improvement. In addition, there was increased financial assistance for folks on Part D and helping people get cover those costs during the coverage gap before it becomes eliminated, phased out completely. An important protection for people on Medicare as well as in private plans is their elimination of copays for certain preventive services. There's a federal body that reviews health services, and it determines those that should be included as preventive and without copay, the notion being that it's in everyone's benefit that everyone access these preventive services. So that was done as well. Under Medicare, there's a whole host of changes either allowed or mandated related to payment. And one is moving forward with a model whereby there may be a procedure such as a hip replacement, and all those costs are added together, bundled together. There's an estimate made of what the average costs are. That's paid then to the provider, and they then have to manage the care of that individual within that amount. So there's that bundled payment. There's other capitated payment arrangements. And then most broadly is the establishment of a CMS Innovation Center, which its mission is to see if they can identify additional payment methodologies that would advance quality and reduce costs in a variety of ways. What's referred to as CMI, or the Innovation Center, has made outreach to Indian country in terms of seeing if there can be initiatives that tribes and IHS might support, might bring to the Innovation Center, and that offer remains there. And so folks might want to, either working through TTAG, Tribal Self-Governance, NIHB, NCAI, might want to bring suggestions on their own or through those organizations to CMS to see if we can put in place payment methodologies that would benefit Indian country, might need a particular wrinkle that would add to the value in remote areas and things like that. So we looked at Medicaid, we looked at Medicare, and now with the marketplace, we have the health insurance marketplaces that were established in each state. Basically, those allow consumers in what's called the individual market, people that are buying insurance outside of their employer, outside of a public program like Medicare or Medicaid, to go and compare options for health insurance. Some of those options are largely standardized, so you can compare one plan to another that's being offered, and then look at the price. And in that process, be determined whether you're eligible for federal assistance in the form of one of two types: premium tax credits, which are for certain individuals between 100 and 400% of the federal poverty level, and secondly, cost-sharing protections. One set of cost-sharing protections are for the general population, and then there are Indian-specific cost-sharing protections that are comprehensive for enrolled tribal members. So as the second half of the slide there identifies American Indian Alaska Native marketplace protections. Number one, as I mentioned, comprehensive cost-sharing protections. These apply, though, to enrolled tribal members, but not other IHS eligible individuals. So you might have a family that enrolls for coverage through the marketplace. There might be 5 members, of which 2 may be enrolled tribal members and 3 are not. So those that are eligible for the comprehensive cost-sharing protections would enroll together in one plan, get those protections. The other family members would enroll through the marketplace at the same time, but they technically be in another plan. And they, though, may be eligible for the general cost-sharing protections, which are significant, but nowhere near as comprehensive as the Indian-specific cost-sharing protections. There's a ban on marketplace plans reducing payments to Indian healthcare providers by the amount of the cost-sharing that's provided by the federal government. So the health plan can't say, well, you were going to, the patient was going to have to pay $500. They're not now, so we're going to reduce the payment to the provider by $500 because they're going to get those dollars from the federal government. So it doesn't allow that. So what this means, though, is, in particular, is if a enrolled tribal member goes to an IHS or tribal provider, that IHS or tribal provider will get full payment, and they will not have to use the term eat. They will not have to accept no payment for the co-payments or deductibles or what have you from the IHS eligible individual. So it's a great way to bring full payment to tribal and IHS providers, as well as if a tribal member goes to a private provider, the private provider receives full payment both for the base payment amount as well as for any cost sharing there is, and the individual enrolled tribal member does not have to pay deductibles, coinsurance, or co-payments. Two other items that are specific to American Indians, Alaska Natives: monthly special enrollment periods. So rather than have solely the general open enrollment period that comes right before the beginning of the calendar year, the American Indians, Alaska Natives who are enrolled tribal members can enroll any time of the year, as well as any of their dependents, IHS eligible or not, can enroll as well. And then finally, exemption from the requirement to have health insurance or pay a penalty. There's an exemption right up front for enrolled tribal members that was expanded to all IHS eligible individuals. As you may recall, though, more recently, Congress passed an exemption or elimination of the penalty component. It's technically still a requirement to have coverage, but the penalty got reduced to zero for the entire population, American Indians as well as the general population there. A couple other provisions in the Affordable Care Act pertain to the employer market. The first, most significant requirement is that for employers that have the label large, 50 full-time employees or more, or full-time equivalent employees or more, they're required to either offer coverage to their employees and pay a portion of it, or make a payment to the federal government somewhere in the around $2,300 a year per employee. So they have to, in the vernacular of pay or play. So the play is, I will, as an employer, offer coverage. The pay is, I will not do that if I don't, as an employer, I may not find that beneficial. I'll make a payment to the federal government, and then those individuals that are my employees can go in possibly into the marketplace and get coverage, or maybe they get coverage through their spouse or family member. There's also reporting requirements for employers of this size, 50 or more, and it's the employer mandate applies to tribal governments, it applies to state governments, it applies to nonprofits. It broadly applies across all employer types there. It actually doesn't apply to the federal government, but the federal government has in place laws that require offering of coverage to their full-time employees there. Another item that was established, in addition to the marketplace that was set up for the individual market, there was kind of a marketplace equivalent, or what's referred to as the SHOP, Small Business Health Options Program, that was established for small employers, employers with between 1 and 50 full-time employees. And the idea there was sometimes small employers have a hard time finding affordable insurance. So the SHOP would be an option for small employers, tribal, non-tribal, what have you, that might want to look and see if they want to purchase insurance for their tribal members through that mechanism, rather than contracting directly out with a health plan or offering self-insurance coverage where the employer would be at risk for the claims themselves. So the SHOP is there, it's available. It has its own set of assistance, federal assistance, but it's pretty modest, and it only applies to the firms that have 1 to 25 full-time employees and more modest income. It doesn't apply to every employer. Those with higher average incomes of the employees are excluded. So it's worth taking a look at. You can go online, type in, SHOP or Small Business Health Options Program, and look what the offerings are in your area to see if it may be preferable to the insurance that you might have if you are considered a small employer. So just one last point on that. A small employer might be that a tribe has set up an entity to do some specific thing, an enterprise or what have you, that operates outside of the core operations of the government. For federal purposes, ERISA law and what have you, it may be considered its own entity, and so it would not be counted with all the other employees and could be considered a small employer for these purposes. In the Indian Healthcare Improvement and Reauthorization and Extension Act, which again was added to, combined with the Affordable Care Act and enacted with it. There are a number of provisions that are important, helpful, and advantageous to Indian country. And I'll just walk through the list that's showing on the screen there. Number one is that what's authorized as medical services that are allowable for funds to be expended on IHS appropriation, as well as third-party revenues. There's a list of additional services to kind of update the Indian Healthcare Improvement Act, such as including long-term care services and some other specific services that were not identified previously. So it's a much more comprehensive list of authorized services. Just an important point, though, there were not funds that were appropriated that said, now that you can provide long-term care services, here is an additional amount of appropriated dollars to do that. That was not included. It was just the general authorization in the Indian Healthcare Improvement Act. Secondly, clarifies tribes have the ability to use the IHS appropriation and third-party revenues that are collected by a tribe. The tribe can use those funds to purchase health insurance for IHS eligible individuals, which is oftentimes referred to as sponsorship. That's under Section 402 of the Indian Healthcare Improvement Act. That has proven to be very helpful, both the clarifications, but just the general ability to do it. As you've seen in other presentations, tribes are increasingly using the marketplace to secure additional federal subsidies, get more active users enrolled, and sometimes supplementing their funds, bringing in the federal dollars. And again, clarified under Section 402 that that's permissible at the option of a tribe as to whether they want to do that. Right of third-party reimbursement for services, Section 206. This was also revised. This is that if a tribe or IHS provides services to an IHS eligible individual, and that individual has health insurance coverage, that the IHS or tribe can bill that health insurance company, whether the IHS or tribal provider is an in-network provider. It's an absolute ability for, again, IHS and tribal providers to bill the coverage that an individual IHS eligible individual has. There's provisions about what the rates may or may not be in Section 206, but as a fallback, this is a very important provision to ensure that resources come into the Indian health system to support services that are provided for people who do have health insurance coverage. Another item there allows IHS, tribal, urban Indian programs to purchase federal employee health or life insurance through the federal system. And so this is in particular FEHB, Federal Employees Health Benefit. So a number of tribes, I think it's up to over 100 entities, tribes, tribal health organizations, are purchasing insurance through the FEHB for their employees. And it works pretty well that a tribe can look at what their average costs are now as a self-insured plan or buying insurance on the market, and then can compare that with what the rates are under FEHB. The plans under FEHB, there's 5 national plans as well as local plans, and you can figure out what works best for your tribe. So it's well worth looking at. On the second item there, life insurance, the federal government, Office of Personnel Management, has not set up the life insurance component yet. They found that there was not great interest to date, so that hasn't been implemented. If that is of interest to tribes, they could bring that to tribal organizations or themselves and communicate that would be important if they could add that. Expands IHS collaboration between the VA and Department of Defense, and so there's some clarification of what's allowable there, sharing of facilities and things of the like. And then finally, provides for additional grants and funding for health programs. There is, under that link below, a Congressional Research Service, CRS, report that goes through every provision in the Indian Healthcare Improvement Reauthorization Extension Act and gives a summary of it and what the intention of it is. And that's a very helpful document for sometimes interpreting sometimes less than clear statutory language. So that's really a good resource to have. Moving on in terms of funding for the Affordable Care Act, so we went through what the kind of new benefits are under Medicare, under Medicaid, the marketplace, subsidies, and what have you. Well, how's that paid for? Just going through that real quickly. One is government has been paying under Medicare and Medicaid extra payments, oftentimes referred to as DISH payments, that get added on for in-hospital care to cover costs of people who come in and do not have insurance. A lot of those dollars were removed from these add-on DISH payments and moved over to fund the direct subsidies to individuals. So there's still DISH dollars going out, but they was reduced significantly under both Medicare and under Medicaid. There are some taxes under the Affordable Care Act, net investment tax they're showing. So 3.8% tax on individuals and estates, above $200,000 for an individual, $250,000 for a family. So there's a tax on income at that amount. Additional Medicare tax was added on, again, with those thresholds of $200,000 for an individual, $250,000 for a family. So when paying the Medicare tax, a 0.9% additional tax is levied on the income above those thresholds. Then some of the providers in the mix were also subject to taxes. Health insurers pay a tax. Medical device entities are asked to pay a tax. Tanning services to pay a tax. The idea with the insurer tax there in particular is that insurers will have a lot more customers, and it made sense that they kind of contribute to the overall funding in the mix there. Medical device manufacturers, particularly with the standardization of the health benefits, ensuring that everyone has comprehensive access to services. The notion there was medical device manufacturers would be benefiting from that, and just a small portion of their gain would be taxed and brought back in. The employer mandate, the pay or play option, relieves some of the pressure on programs because employers may be offering coverage, or for employers that don't offer coverage, that pay provision brings in revenues to the federal government. The individual mandate doesn't apply now in terms of that the penalty if you don't get insurance, but initially it was generating some revenue to the federal government because individuals who didn't buy it may then go on the marketplace and get subsidies, maybe on Medicaid, and so the individual mandate was partial payment for those protections that folks would get. And then finally, there was an excise tax that would come into play in the future, and it would tax high-cost plans. So as an employer today, the value of the health insurance that someone gets through their employer is not taxed. The excise tax on what's referred to a Cadillac tax, high-cost plans would say, if your plan is asking for deduction more than a certain amount, then that amount over the threshold would be taxed. Just as a side note, over the last few months, the House passed a rescission of this provision. The Senate hasn't taken it up, but it may be something that doesn't kick in at all. It was scheduled to kick in 2020, and it was kicked out through 2022, so it hasn't been put into effect at all right now there. So just last slide here on this section on the ACA provisions here in the marketplace. So we see the benefits that in payments for the tax credit, the costs, premium tax credit, $49 billion a year in 2018 going out. Small business tax credit, another $1 billion, and then the taxes there that are coming in to support that. We see $13 million in net revenues over the cost of the marketplace subsidies. That $13 billion is then used on to offset the cost of the Medicaid expansion. So you can get a kind of feel for what the expenditures are under the Affordable Care Act and where the funds come to offset those costs. So in the next section here, Medicaid enrollment, we're just going to look at the impact of the Affordable Care Act with a couple slides. Won't go into great deal, but just so that you have a reference here. If you wanted to communicate to leadership within your tribe, or if you want to communicate it to elected representatives, how important the Affordable Care Act is, some of these numbers might be helpful. What we see on the slide on the screen now is looking at estimate of the growth in enrollment of IHS eligible individuals. We've got it broken down by states that expanded Medicaid and states that have not yet expanded Medicaid. And we see that on the far right percentage gain, there's been a 41% increase in the number of IHS eligible individuals enrolled in Medicaid coverage since the enactment of the Affordable Care Act in 2010, 41% gain. In states that didn't expand Medicaid, there's been a gain, 21%, but obviously it's not as great. Overall, 34% increase in IHS eligible individuals with Medicaid coverage. Just some down below it identifies the definition of IHS eligible individuals here. This is coming from the census data where these numbers are taken from. We've got the data by year by state on this slide and on the next slide. This slide is indicating all the states that have expanded Medicaid, and the next slide shows states that have not expanded Medicaid under the ACA authority. But under each one, you can see what growth there has been. And then on the far right-hand column, it's an estimate of the number of IHS eligible individuals who may be eligible for Medicaid today if they were to apply to enroll, or on the slide with non-expansion states, it indicates the number of individuals that may be able to enroll if the state were to expand Medicaid coverage. So that's on the slide here. Next slide down. There's this one, there's a set of calculations on the screen here. The average expenditure across the country for all populations enrolled in Medicaid expansion is about $5,600 for 2017. That's now over $6,000 per enrollee. So if we just take the aggregate number of individuals that, IHS eligible individuals that have gained coverage since the enactment of the Affordable Care Act, multiply that by the $5,600 in terms of expenditures made by the government for those individuals, that's over $646 million a year being spent on the IHS eligible population that wasn't being spent before the Affordable Care Act. Down below is the potential for additional gain, additional revenues being spent on behalf of IHS eligible individuals, whether that's at ITUs or with private providers. But there's about 89,000 individuals who, IHS eligible individuals who could also gain coverage if all the states were to expand, and if we were to do even better enrollment of IHS eligible individuals into Medicaid. That could generate an additional over $500 million a year to meet the healthcare needs of IHS eligible individuals. Just for real quick reference, determination states, this just identifies states that use the federal marketplace for enrollment and into the marketplace, but also into Medicaid. And a determination state is one whereby if the marketplace says you're eligible for Medicaid, that's it, you're enrolled, you're in Medicaid, whereas other states are called referral states or assessment states, where you go to the marketplace, you apply for coverage, determines whether you're marketplace eligible, Medicaid eligible. If you're Medicaid eligible, it refers it to the state, and then you continue with your application process. So for states that have that are determination states, it simplifies things. You go on the marketplace, see if you're Medicaid or marketplace eligible, and you can enroll in either one of them immediately, getting immediate eligibility determination there. Okay. Here on the slide is just a representation across a handful of states that shows the way it works under the Affordable Care Act. Medicaid and CHIP are primary coverage. If you're eligible for those, then that is the primary coverage. If you have an income above that level, then you may be eligible for marketplace coverage. But if you're eligible for Medicaid, you're not eligible for the subsidies under the marketplace. And it shows what the different cutoff levels are for the states that are shown here. Down on the last two lines of this table, CSIO, ECP, contracting requirements, so it's a lot of gibberish there, but what that asks or represents is that in states that the federal government is running the marketplace, the federal government has put in additional protections through the marketplace for Indian healthcare providers, such that a health plan offering to sell coverage through the federal marketplace has to offer a contract to Indian healthcare providers that operate in their service area. Some states have adopted that as well, in states that they're operating on the marketplace on their own. But this represents each of the states here are actually operated at the time by the federal government. And so if you are Indian healthcare provider, IHS, tribal, urban, operating in those states and in other states where the federal government's running the marketplace, you have the ability to receive a contract from the health plans operating in the state. As a provider, you can either accept it, negotiate something different, turn it down, but it's a benefit that it's offered there, so you have a leg up. And the final is, row there is just showing the number of enrolled tribal members and other IHS individuals with coverage in the marketplace as of 2018, the most recent set of data that we have. Nick, how are we doing on time?
Hi, Donnie. We're doing well. We have approximately 10 more minutes left in this webinar, and so far we have 0 questions. So if you have any questions, feel free to text them in the text box.
Excellent. Thank you, Nick. So just going to focus on marketplace enrollment. You have these slides. You can refer to them later, but just want to make some high-level points here on the slide showing what we see. If you focus in particular on the darker shaded area, that represents enrolled tribal members enrolled in the marketplace. The lighter shaded are other IHS eligible individuals enrolled in the marketplace. And what we see is greater and greater enrollment year by year in the marketplace by tribal members or other IHS individuals. And in particular, if you look at the enrolled tribal members that are eligible for tax credits as well as comprehensive cost sharing protections, enrollment has been growing 17%, 20%, 18% a year. That's tremendous growth. In particular, if you compare that to the enrollment growth for the general population, in 2018 it was pretty much flat, a 0% increase. So 18.6% increase really is a tremendous increase, and showing that tribes and individuals, tribal members and others are learning of the value of enrolling in the marketplace with the federal assistance. Sometimes that assistance is sufficient enough to actually reduce the health insurance premium all the way to 0. And for enrolled tribal members, no out-of-pocket costs, so that full comprehensive coverage could be no premium and no out-of-pocket costs going through the marketplace. These are just a little bit more detail about enrollment in the marketplace. What we have on the screen here are enrolled tribal members in the first 3 columns of data, and then we have other IHS eligible individuals enrolled in the marketplace by state for 2017 and 2018. We can see what those numbers are. We can see what the change has been. And so the federal government provides these reports annually to the Tribal Technical Advisory Group and to Tribal Self-Governance Advisory Committee, and we put these materials out. Just to highlight one state in particular on enrollment growth here is Oklahoma. That from 17 to 18 had a 35% increase in enrollment, and that was on a base of 13,000 tribal members enrolled to start with. So tremendous enrollment growth there. And tribes are more and more sponsoring individuals whereby the tribe would pay the premium of their tribal member to get the coverage, and that would then have the benefit of bringing in substantial federal revenues. These numbers that we're showing are for the states in which the federal government is running the marketplace, but we also have data, some data for the states that the state are running the marketplace themselves. So we see here California, Connecticut, what have you, and enrollment changes that have happened in those states. So we have those numbers as well. If you were to, just one more point on the numbers I just showed there, those numbers represent one day of the year. The federal government said, I want to know, as of today, how many people are on marketplace coverage today. There could be some people who enrolled earlier and then disenrolled, or will enroll later in the year and what have you. But those numbers represent how many people are enrolled on that one day. On the screen now, we have a slightly different set of data, which is saying over the course of the whole year in 2018, how many American Indians, Alaska Natives, those who are enrolled tribal members and other IHS eligible individuals, enrolled at some point during the year. The dark blue are for enrolled tribal members. The lighter colored diagonal shape there is for other IHS eligible individuals, both of those through the federal marketplace. And then the gold coverage there, color there, is for enrolled tribal members in state-based marketplaces where the state's running it. So we see that we have just shy of 100,000 individuals covered through marketplace coverage at some point during the year. The subsidies on average are similar to that under Medicaid, which is in that $6,000 range. Under Medicaid, there were 115,000 IHS eligible individuals that gained coverage under Medicaid since 2010. Here we have almost 100,000 individuals. So combined, we have over 200,000 IHS eligible individuals that have gained coverage through Medicaid or the marketplace since the Affordable Care Act kicked in. I'm just going to touch on a couple things we've already reviewed, but we have the slides with some of the detail we can go in later. This is showing kind of just the breadth of federal subsidies that are coming in to meet the federal trust responsibility to tribes and tribal members. And we've had appropriations, and we've had Medicare reimbursement, we have Medicaid reimbursement, now we have Medicaid expansion, and we have the marketplace as the latest mechanism that the federal government is using to meet its federal trust responsibility to tribes. I just want to maybe close to wrap up here with the next two slides, this and the next two, which is the slide here represents what many tribal health organization tribes may have as we look at their active user population and where they get their health insurance coverage and who pays for that. We see some individuals employer coverage, Medicaid coverage, Medicare, a number of uninsured individuals, and then we have the bucket there for the marketplace. And if you look in the areas with the light shaded, that represents appropriated dollars from the federal government, and that's coming in and being used largely for the uninsured population. Then we have dollars coming in from the state, federal, or employer for Medicare, Medicaid, employer coverage with the blue coverage there. But we see gaps. We see areas that are not filled in, representing the unmet healthcare needs that tribes have, and oftentimes leads to the imposition of rationing through priority, authorizing less than all priority levels under the Purchase and Referred Care Program, for instance. So for the uninsured population, many tribes are not able to meet the full needs of their uninsured population. So what a number of tribes are doing is to rearrange the dollars a bit and take some of those dollars that are currently spent on the uninsured, move those individuals and a little bit of the dollars over to the marketplace, allowing the tribe to pull down a whole bunch of federal resources that are represented by that lightly colored red area there. So can tribes better leverage the appropriated dollars to bring in more federal resources? And that's what a number of tribes are doing. So we see on this slide here, it represents the kind of the post phase there, where if we look at the uninsured block there, it's showing the appropriation is covering the whole area of that bar, representing meeting the full needs of those who remain uninsured. But a number of the uninsured in this graphic would have moved over to the marketplace and with some of the federal appropriation to bring down a whole bunch of resources through premium tax credits and cost sharing protections. So then a tribe will be maximizing health insurance coverage where it's available, employer, Medicaid, Medicare, or the marketplace, freeing up, hopefully, some of the appropriated dollars to be spent on services that may not be included in a standard health benefits package, such as to the right, we see long-term support services. Many services are beyond the health benefits of a basic insurance plan. Or if we look to the far left, we see prevention and community health activities that are not fully funded and sometimes not funded at all through the health insurance benefit package. So if a tribe is able to maximize its appropriated dollars by leveraging more federal funds, it may be able to ultimately free up some of those appropriated dollars to spend outside of the basic benefit package. And we see today that a number of tribes have pretty much been able to do that. Maximize coverage to almost 100%, free up funds to then really broaden outreach and services to their tribal community. Just going to do one last example here in the time that we have. And this represents how the resources are secured through a marketplace. And so our little graphic there is for the case of one individual who's an enrolled tribal member who happens to live in Gallup, New Mexico, and they go in the marketplace and say they're uninsured, they don't have an offer of coverage through an employer, and they would like insurance. Their income is above the Medicaid threshold. They make $18,000 a year, 150% of the federal poverty level. And so what would happen if they went to the marketplace? And these are figures, actual based on health plans that are offered. And we see that the total funding to meet the average costs of an enrollee in the marketplace plan there in Gallup is $5,179. A portion of that is covered by the health insurance premium, and a portion of those costs that people have over the course of a year are from out-of-pocket costs. In this case, for this individual living in Gallup, the federal government would actually pay the full $3,378 premium that's required to enroll in this health plan. It happens to be a Blue Cross plan being offered there. The $0 representing right in the middle of the bar graph is that the enrollee themselves, or if the tribe were doing sponsorship, paying the premium on behalf of the enrollee, it's $0. The federal government's paying the full premium. That $1,801 figure there, that represents the average out-of-pocket cost that someone would have over the course of a year if they enrolled in this coverage. So $1,801 that would be coming out of pocket to pay for a portion of the care over the year. Because this is an enrolled tribal member, the federal government will be making those payments of $1,801 to the hospital, for instance, if they go and they have a $500 deductible, or to a specialist for a $45 copay or what have you. So those dollars will be paid out by the federal government. That $0 figure on the top of the bar graph represents the out-of-pocket costs for the enrolled tribal member getting coverage through the marketplace at $0. Again, 100% coverage of the out-of-pocket costs. In this case, the premiums, tax credits, the premium assistance coming from the federal government is enough to cover the full premium. If someone's income were higher, they might have to pay a bit more. But in the case here of someone whose income is above the Medicaid level, full coverage of the premium by the federal government, full coverage of the out-of-pocket costs. So that's just kind of to emphasize the resources that are available through the marketplace that a tribe may want to assist tribal members to access by helping them enroll in the marketplace if they're otherwise uninsured, and possibly paying the premium on their behalf if a tribe would decide to do that. It's all up to all at the discretion of a tribe where they want to engage in what's referred to as tribal insurance sponsorship, but that is an option that some tribes are using to bring in substantial additional federal resources in addition to those that are gained through Medicare and through Medicaid. So, Nicholas, I think we'll wrap it up there, if that works for you.
Thank you, Donnie. Again, this is Nicholas Courtney, Policy Analyst with the National Congress of American Indians. We're extremely grateful for all of you viewing today, and we'll be sending a copy of this webinar or webinar materials to those interested. Please email me at courtney@ncai.org if you have any questions. Thank you again and have a wonderful day.